I've been operating on eyes for more than 20 years on 3 different continents. I'm passionate about helping people keep their eye health and make good lifestyle choices.
I look after the part of the eye responsible for seeing colour, reading, looking at your loved ones. It's your macula and your retina. I look after diabetic eye disease, AMD, genetics, and inflammation.
This is the EyePros Podcast.
I'm Yasmin Abdullah.
I'm Ahmed, and this is Know Your Consultant. Right, we've decided to flip the format completely today, which feels bizarre, to be honest. I've been on international glaucoma conferences. I've been on the interventional podcast with people like Professor Ahmed and Professor Gus Guzzard, and somehow this feels more intimidating.
Well, you've got every right to be intimidated. I've prepared some questions, and I know where all the skeletons are buried.
Oh, right.
Right, so let's go back to the beginning. When you're a wide-eyed graduate of Alexandria University Medical School, what made you want to go to ophthalmology?
My father was a professor of ophthalmology. He was a very well-renowned person, known everywhere. He was very passionate about students, teaching people. He would bring his material at home. We had those slides back in the day, so we didn't have all these PowerPoints and things like that. He'd have slides and he would project them on the walls of our living room, and I would sit next to him looking at all the slides and all the content. And ever since then, I just saw it as a natural thing. And then when I actually went to medical school, I saw the beauty of ophthalmology, how it's a very wide field. It has just the right amount of mixture between surgery and medicine. It has research, it has all the science, it has neuroscience, it has hemodynamics, it has hydrodynamics. It's brilliant, and it affects people deeply as well. Your sight is the most important thing in your life, and most people tell us that. So I just felt that it's just the right combination of everything.
And I did go to the same medical school as you, and I remember how sciencey you were, for the lack of a better term. So moving on, tell us about your time in Wills Eye Hospital in Philadelphia.
This was really transformative to me. We're very lucky to get accepted. I think they get 800 applications every year, but they just saw something in us. You were with me, weren't you? This is when we started the scientific collaborations. We wrote, I think, 5 papers back then together. It's a really transformative year. Although I spent it in the cornea service, external eye disease, so the dry eyes and all your ocular inflammation and refractive surgery, corneal surgery, but also it's being at Wills Eye Hospital. So Wills Eye Hospital, for context, it's one of the biggest hospitals in the world. It is the first dedicated eye hospital in the US, started in the 1800s, back when Philadelphia was actually the capital of the US, and this is where it's based. And it's being among these people. Most ophthalmology was invented there. Cataract surgery was invented there. Vitrectomy, retinal surgery was invented there. Most of the diseases were named by Wills Eye Hospital. In the cornea, they have all the diseases, all the dystrophies. They were named by those professors that there. And I worked alongside people like Peter Leibson, who really introduced cornea as its own subspecialty. I was very lucky. But also people in other places. We had those grand rounds, if you remember. So we would attend something at lunchtime or at 6 in the morning, and they would have something at 6:15, which is 5:45 in the morning. And they just started that early, and we never finished before 7 o'clock. And it's all scientific input and seeing patients in clinical. We would see things that were actually not in the books. And we go to Chris, one of our attendants, and we would ask him.
Chris Rapolano.
Yes, and would ask him about this, and he'd be like, yes, I saw this in one family in Saudi Arabia. I remember that very well. Yeah. It wasn't in any books, and he knew it.
Yeah.
And being among these people, attending those rounds about neuro-ophthalmology or glaucoma, which I actually spent some time in glaucoma service as well, and that was also, it really shaped what I do now, still these days, although this was 2007, so almost 20 years ago.
Walking amongst legends.
Yes, of course. And I was good buddies with Ed Jaeger, who invented the Jaeger chart to see, test your near vision. transformative time. And, all that time is about 15 months altogether. That was, really shaped
It's
how I
such a
look
privilege.
Yes, and the research vigilance, how they inform knowledge and inform how clinical practice happens, and the research trials and all that. And we had the Discovery Channel film with us. Remember one day we had a war veteran that had dry eyes, and she almost committed suicide, not because of all the war stuff, but because of her dry eyes. And but we helped her at Wales to maintain a good lifestyle and control her dry eye disease, and she felt very grateful for that. And there's many stories about that, because people came from all over the world to see those doctors. So it's really a transformative time, and it affects my clinical practice to this day.
So after the US, you went briefly to Egypt. Can you tell us a little bit about that?
Yeah, so obviously went back. I had my experience in corneal disease and glaucoma. Started my own practice. It wasn't the easiest time, because there were problems with eye banking, so we didn't have eye banks in Egypt. There were logistics problems, legislation problems as well. But I did work in something called the Egyptian Ophthalmic Group, which was a nationwide group of eye clinics, and I was the medical manager of one of the clinics in my city, Alexandria. So we did a lot of refractive surgery. I was involved in the day-to-day, management of this stuff, and training doctors and doing my own laser surgery and cataract surgery back then. And I was, I think, wrapping up my master's degree as well, so which was also in lasers. And it wasn't just so, obviously, it was focused on laser eye surgery, but I learned a lot about lasers, and this shaped my experience in linking everything together, what I do now. Eventually, I felt inspired to explore elsewhere, and the lack of eye banking was a bit of a problem back then. So this is when I sought opportunities in the UK.
Right, so tell us about your time in the UK. Tell us about Southampton. That's where things get really exciting.
Yeah, so it was a very exciting time in my life as well, because there was this corneal fellow post, and it's usually a very competitive post, but when I interviewed there, they really liked what I learned in Wills Eye Hospital, and it's strange how things work out, but the head of service, the head of cornea service, and he was also the clinical lead for the department, David Anderson, he's a good friend of mine still, and we just connected on that day on the interview, and despite me not having a lot of UK experience, he just felt that I have very good corneal experience on all the research publications we published. All those 5 papers were very important in the corneal field. So they gave me the job, although other people told me it's a very competitive job, we might not get it. But we did get it. And it was, again, one of the transformative parts of my career. I learned a lot about corneal surgery, complex cataract surgery, started back then in 2009. It's about 16, 17 years ago now. And just being in that environment. They were very academic in Southampton. So my other consultant, Professor Parvez Hussain, he was heavily involved in research on the academic side, and I always aspired to do more research, and just seeing him doing this, and we were always linking that. Obviously, with Professor Lotri, he worked with in medical retina. We had those eye rounds. We would have an eye research meeting as well. So I got inspired with that, and I expressed an interest in doing more research to him just very early on, and he said, "Well, I don't know you, mate, and I just need to see how you get on first." But I really enjoyed the job. I really liked seeing patients in the corneal clinic, helping them, looking after patients on the wards,
But you eventually acquired a PhD.
Yes, so he eventually, we applied for a studentship. He had a line of research happening, and he needed someone to carry on with that. So applied for a studentship. He said, "Look, if you'd like to do a PhD, like he said," I love that, and applied for the studentship. Got the studentship with the British Council for the Prevention of Blindness.
Right.
We got the studentship to do my PhD. And it was about ocular inflammation and infection. So we studied a specific model about contact lens related infections.
So a lot of patients would be surprised that it was a lab-based research.
Yes, so this was properly lab-based. There was no patient contact. I mean, I did ask for me to still be involved in clinics. So I would do clinics. I would do some theaters as well. I helped around the department when people were, away or, having covering on calls and things like that. But it was mostly working on the bench, protein assessments, bacteria, cultures.
So how did that affect your clinical practice moving forward? Did it have an impact on your patient care moving forward?
Yes, I mean, I always go back to the basics. I always like basic science. You've always called me a nerd for that. And it's always been that I always go back to how diseases start. So when I see a patient in clinic now, I know that this is how the infection starts, because from the lab, and it informs my practice. So I know that bacteria would grow inside the cell and destroy the cell within 8 to 12 hours. So this is an emergency. I have to treat those patients. I've seen what happens. I've seen how the antibiotics go into cells. So I know what antibiotics to use, etc. But also even in unrelated fields like glaucoma, let's say, I always go back to the mechanics and how the disease progresses and what starts the disease, why it happens, and always want to treat the actual cause of the disease. So it gave me this academic acumen, I call it. I like that, and I also developed my love for academia, for education, for teaching people as well. But it does really inform my clinical practice. It's about going back to basics and having that in the back of my mind. I know how to read scientific papers and be part of clinical trials.
Right. So after that, you did something quite unusual. You worked for the industry as an Alcon and Alimera Sciences as a medical director, I believe.
Yes. So right after my PhD, got a headhunter knocking the door saying we need a medical director for Alcon. And obviously Alcon is one of the big pharmaceutical companies.
Of course, all our phaco machines come from
Alcon.
All
the cataract surgery machines and many drops and everything. So they were looking for a medical director. They put me forward, and it was a very tough interview process, actually. They had 165 applicants or something like that. And but they saw something in me, and I said I wanted to try this because working in the industry gives you this perspective of how medicine is done on an industrial level, how clinical trials are done, how you introduce a new medicine, and how the regulatory part of it as well. And I was involved in all of that, marketing. And Alcon had many branches. It had medical branches, so drops, especially glaucoma drops, and anti-inflammatory drops. They had the surgical part, which was about all the machinery, all the lenses that go into your eye, the development of lenses, which I found incredibly interesting. How the multifocal technology, extended depth focus, was just coming in at that point, and they had the contact lens part as well. How the technology informs practice, infections, all these things obviously came right up my alley. And then Alimera Science is a very different thing. They're
up my alley.
Yes, they are, because they treated inflammation and diabetes, but they also saw that because of my PhD in ocular inflammation, they found that this could be useful, and it was very, very useful. But they wanted me to have a more European role because it was a bit smaller company. Mm-hmm. I found that very exciting as well. So I got exposed to different health systems around Europe as well. How the regulatory process, how clinical development, new drugs being, this was a new drug.
Right.
So I found that also inspiring, and it just informed my practice today as well, and what I do as head of service now, and even things like minimally invasive glaucoma surgery, all these devices, new devices, I like to be involved in that.
So you think that this time in industry helped you with your MIGS kind of experience and how you adopt MIGS?
Yes, absolutely. So I experienced that, other side of the table, so how to develop a new medicine or device, right, and how to introduce it into the market, and how to engage clinicians as well. And I knew this when they what they think about and what they want for patients and how to develop it. So And it helped me adopt new technology as well. So I like all these new technologies and how they the different devices. We have 6 or 7 devices now, but how every single one of them has a different function and what to choose for different patients.
And for our listeners, MIGS is minimally invasive glaucoma surgery. So in simple terms, it helps you get rid of some drops to maintain a better lifestyle with good pressures in your eye?
Yeah.
For simplification reasoning, obviously.
Yeah. So obviously glaucoma mostly is about the pressure in the eye being too high for your optic nerve.
Yeah.
And it starts crushing the optic nerve coming out of the eye, which is obviously the cable that takes all the information back to the brain. So we need to reduce the pressure. And classically, we've been doing this with drops. Some patients it works really well. Some patients it doesn't work as well, and we need something else. So MIGS were introduced about 15 years ago, I would say, and they work in the anterior part of the eye, so something called the anterior chamber angle, trabecular meshwork. So this is with the filter where the water comes out of the eye. So in glaucoma, it gets clogged. It's like a filter that gets clogged and doesn't allow the water to come out. And it's almost like plumbing, really. So you got water coming in, water going out of the eye. So the MIGS devices or procedures, they bypass the trabecular meshwork, so the pressure doesn't build up in the eye. Works really well for about 80% of patients. But for patients, when they are on drops and it's time for cataract surgery or lens replacement, they would have the MIGS device as well. It takes about 5 to 7 additional minutes. Not really much more risk to cataract surgery because it's done at the same time. So we're in the eye already. We're right there. So we do this procedure to reduce the pressure, and it works very well for many patients.
Before moving on from glaucoma to cataract surgery, I'd like to ask you about Excimer laser for glaucoma. I know you're one of the early adopters for that. Can you tell us maybe a couple of things about that?
Yeah, it's very exciting actually, because Excimer laser is the laser we use for laser refractive surgery, for getting rid of glasses, LASIK, PRK, and all these things. And this was the subject of my master's degree in Egypt. So I had a lot of experience with that, and also in my own Wills Eye Hospital or when I worked in the Egyptian ophthalmic group. So when this was announced that they have this Excimer laser also developed to reduce the pressure in the eye and as a MIGS procedure. I found that's very exciting, and they found that my expertise is very helpful for them. So I was invited to be a guest on the Intervention Glaucoma podcast with Professor Gus Gozzard and Professor Ahmed, and also in a webcast as well, talking about this because I knew the theoretical part of how that laser works. It's a cold laser, it doesn't burn things. It's not like people always think about lasers like in Star Wars, where there's a laser that cuts through metal and things like that and destroys ships. And in the eyes, it's not like that. It's far from that. It's a cold laser and it's a very controlled device, but it works very well. So when this was introduced, I was really excited about it, and I was an early adopter and helped introduce that to many other clinicians in the UK.
That's fantastic. So moving to a slightly different part but similar in your practice, which is your premium cataract surgery. And I know you do combine that, as you said, with your MIGS at times.
Yes.
You also do a lot of refractive laser surgery.
Yes.
Can you tell us a bit about that?
Yeah, it's it's that part. So people develop cataract as part of aging. Everybody develops that, and when we take the cataract surgery, it's when the natural lens in the eye becomes cloudy. So you have 2 lenses in your eyes. You have the cornea and you have the lens. And the lens becomes cloudy and becomes less functional. So many people lose the ability to read after the age 40, 45. They start struggling with that. And then the lens actually becomes cloudy in your maybe 70s. It becomes cloudy for everyone. It just happens to everyone. It's not a disease. It's just a natural aging process. Correct. So when this happens, patients come to see me. I see this as an opportunity because we're taking that cloudy lens out. So why not put a lens that can give them better vision all around? It's not just distance vision, because this is what people classically take the cloudy lens out, put a new clear lens in, and be done with it. And you get very, very good distance vision. But how about reading vision?
Just like the NHS, where we offer monofocal lenses to everybody.
And it's a great option. But if we go the extra mile, unfortunately, it's not offered in the NHS, and people have to pursue private treatment for that, at least in the UK. But it's at least an option to consider, because you might have the option where you don't need glasses at all, not for distance, not for intermediate, not for near. And it's now we have those extended depth focus lenses where you have continuous good vision from near to intermediate to distance without compromising on quality of vision or contrast or anything like that. And when patients come to see us, they get rid of their glasses completely. Not 100%, I'll say about maybe 95%. So you get by for most tasks.
That's a very good number.
It is. And I mean, I'm starting to struggle myself with that. I'm thinking about all the options where, reading, I wish I had like maybe longer hands and big lights all the time. I know how patients struggle with that. But it is an option to consider. Why not have that? And even economically, you pay for this privately, but you don't have to pay for all your varifocal glasses, which can be very expensive every year. You can, if you want to, you'll have some glasses at home, but you don't need to rely on them. It doesn't affect your lifestyle. So this is what...
It's an adjuvant, not like a necessity.
Yeah, really. And it's a good lifestyle choice, but it's, for people who do it, they'll never look back. They'll
Especially if they're active and, they want to do sports.
Of course.
They don't want to have glasses on.
Yeah, exactly, of course. And also going on holiday or doing, extracurricular activities, or even at work. I had somebody who does diving as a professional diver as well. And he needs to be aware of everything. Obviously, he needs to be aware of his surrounding. He needs to be looking at his dive computer at almost like iPhone distance or your smartphone distance, but also the task at hand, intermediate, like welding or whatever. And he came to me. Obviously, the pressure was on because, this had to absolutely go right for him. Otherwise, he would just lose his career. But he was very happy afterwards because he just couldn't do that. How would you do that with a dive mask on? It's very, very difficult. So it really transformed his life as well, changing that. Now, I also have this nice niche and interest in combining extended depth focus lenses, which don't affect the contrast sensitivity, with MIGS. So patients who come to see me, obviously they have glaucoma. We can put the MIGS in, we can take the cataract out. So these are therapeutic things. But also, why not also benefit from the extended depth focus lenses and not having to wear glasses afterwards? So we've been combining that, and we're with very good results as well.
So people who don't have cataracts nor glaucoma, they can still get rid of their glasses, correct?
Yeah, of course. So, and it depends on age really. If they are below the age of 40, then we usually offer laser eye surgery. We can offer the laser eye surgery up to maybe the age of 60. But because we do the laser in the cornea, which is the first lens of the eye, then, it works really well when you have a healthy crystalline lens or the second lens of the eye. If you don't have that when you start out at the age of 40, 45, and the lens starts to have those changes and it's not working very well, and it will become cloudy later on, why not address that? That's what's called lens replacement surgery. And the good thing about that is that you can have laser eye surgery that corrects for distance and near and intermediate, but this it doesn't develop, it doesn't change. So at some point you may need, top-ups or other things. And at some point you need your cloudy lens removed like everybody else, the cataract. So we sometimes just do the lens replacement, which can give you good vision for distance, intermediate and near without having cataract. So this is purely a lifestyle choice. But it's safer than having glasses that can break on your surface or contact lenses that can cause an infection, which are very, very rare. But this is how rare
that could be devastating.
Yeah, yes, but also if you have surgery, it's rarer to have, complications or anything. Obviously, every surgery has complications, but it's accepted because it will really change your lifestyle. And if you have glaucoma, you can have MIGS with a lens replacement. Clear lens have that. And I had a patient who I think she was 37, very high flying, financial director in a big hospital, came to see me. She had glaucoma, which is angle closure glaucoma. So the lens had to come out, but also we put the MIGS device, we put an eye stent in her eyes, and now she's drop free. She's not on any drops, after being on 3 drops, and she's stabilized. She can see distance and near and everything. So it's really transformed their life as well.
It's good that you've mentioned that, because I read a review on Top Doctor talking about eye stent in a closed angle glaucoma. Was it similar to this lady?
Yes. So it's many people come to see me and they have this risk of developing angle closure glaucoma. So their eyes are a bit smaller, so there's not as much space in the eye. So the water can kind of get trapped in the eye and pressure can build up. Essentially, it's just if we remove the lens of the eye, then the pressure can be controlled. But if they're on drops already, then there might be an element of what we call trabecular dysfunction, so the water getting stuck because of that filter, the trabecular meshwork. So many of my patients, they come in, they have the surgery, so we remove the lens, but while we're at it, we put an extended depth of focus lens as well, so they see distance and near and intermediate, and we put the drops. So many of them, if we put the MIGS in or the stents, they come out with 3 drops and 3 glasses, no intermediate, near, or distance, and no 3 drops. So come in with 3 drops and 3 glasses, come out with nothing. And it doesn't work as well with everyone, but it helps most patients. Most of my patients achieve that. No glasses and no drops.
Right, fantastic. So the last question, which is a very combined question. So you're clinical lead in Sherwood Forest Hospitals. You're also an associate professor at Nottingham University and a senior lecturer in Aston University.
Yes.
How do you juggle all these roles?
So it just combines all my passions. They're not very separate. So yeah, head of service, it's about service development across ophthalmology in the region in Nottinghamshire, because I work closely with people in the University of Nottingham, the hospitals, Nottingham University hospitals and Queen Medical Centre. So it's around the region. So working with developing those pathways, and education is part of that. So as an assistant professor in Nottingham, I teach medical students and the trainees that come to us as well, and working with the optometrists. So in Aston University, this is the glaucoma certificate. They have that, and now they become certified to treat glaucoma in the community, which is I'm very passionate about, because there's just too many patients that have a risk for glaucoma. About 10% of the population will have a risk of glaucoma, so they need to be looked after in the community. So training the optometrists to be able to do that and refer the patients appropriately to us, it's all linked really. So and it just helps me in just maintaining that kind of scope of practice among the service development and teaching and doing the premium things and helping the patients, and that's what I love.
Beautiful. That was very inspiring.
Thank you. I'm glad you found it useful. You know all about it.
I hope all the listeners found it useful as well.
Yeah.
Thank you for that.